Wonderful time of the year with all new Very Merry movies all season long on City TV. Or stream on City TV Plus, the app, or citytv.com.
We can be hurt. We can be bruised. We can be broken. Slowed down, confused, and even numbed. But we can't be defeated. We're built on a foundation that's strong, our mission unwavering, and together we'll beat as one.
You're watching Rogers TV, Midland.
Good evening, and welcome to all of you in front of me. Nice to have a happy crowd. I can see your faces here. Thanks for your interest in tonight's program, What's Up with Healthcare? My name is Keith Rose, and I am your moderator for this, our 47th Our Health program. We're very pleased that you're joining us either here in the Midland Cultural Center, or whether you're at home in your lounge chair watching us on Rogers TV, or if you're streaming the broadcast live on your electronic device. So all three modes are available to you all anytime, but it's nice that we've got that opportunity when it's cold or when you've got a cold and you can't come. So great. So it's my pleasure at this point to introduce right away our four speakers. I've got it out of order here because I had you sitting somewhere else, but that's okay. So Rose Zacharias is sitting in the middle. Thanks. Rose is the current president of the Ontario Medical Association, and she's a physician in emergency and hospitalist medicine currently, but has done the full gamut of family practice over her 20 years of her career. She lives in Oro-Medonte. So welcome, Rose, and thanks for coming you came from Toronto today? Mm-hmm. Yes, thank you. The other members of our panel are all local and engaged citizens who access their health in our community. And users of the system are key voices when it comes to change or understanding what's wrong or what's right. So we're very happy to have you here as users of the system. They have lots of questions, and we are definitely looking forward to having the three of you be part of the discussion. Lisa Belcourt, who's sitting right next to me here, is a lawyer, and she has a disability and accessibility advocate of a large group of patients that are compromised in their activities. So thanks, Lisa, for joining us. Jamie Tripp, over there with the beard. Jamie is a former owner of a paint store. He's changed careers. He's brewing craft beer now, and he's opening up a restaurant and a pub and a confectionery. So I think why we asked you, Jamie, is because you have the finger on the pulse of people in Midland, because they come in and they share their woes with you. So many other reasons why we asked you, Jamie, but that was one of them. So thanks for joining us, Jamie.
No problem.
Now, on your posters, we indicated that Mary Warnock was scheduled to be with us tonight. Unfortunately, Mary is under the weather, and I'm happy that she's watching from home. We are missing her, but I am also happy to introduce Sandy Boucher, who's one of the members of the advisory committee and one of the key organizers for this event, who has volunteered to fill in, sorry, Sandy, for Mary tonight. Mary gave her a long list of questions that she had prepared, and thank you, Mary, for doing that. And Sandy's going to reference some of those questions and some of her own ideas. So welcome to the three of you. More detailed biographies are available in got it here, in the electronic version of your program. Nice color here, just can't reach it. Doesn't really matter. But it came during the last 2 MCC blurbs, and there was a link to the program here, and you can see and find out more about our speakers from that program. Thanks. I have a few thank yous before we start. Our Health Advisory Committee, Sandy Boucher, thank you for organizing this, and to all the other members who assist us. To our 7 local sponsors, who I'll talk about a little bit later. To the extraordinary staff here at the MCC, Michelle for promotions, Glenn, who's up in the booth for AV setup, the volunteers, either at the box office, the people who guided your seats tonight, the people who did the setup. So the MCC is invaluable to the work we do. And I must mention Rogers TV. Josh is hiding up there in the booth. The cameras aren't on the wall. He's got a computer up there that's controlling them. And Josh and Rogers have been instrumental in bringing the program, in initiating the online portion of the program and the live tonight, which I must admit I didn't realize the challenges with online productions live. And we've seen some of them, but I think tonight it's going to be smooth sailing. So thank you to all you people. My opening comments, now more than ever, we hear about the challenges in healthcare. When I was preparing for this program, I made a long list of the challenges, and it was long. The availability of primary care was at the top of my list. So tonight, our goals are to have an opportunity for all of us to better understand what's really going on. I'm sure we'll hear both negative and positive stories, and we want to shed some light on the causes of those challenges. And I'm also hoping that we'll hear some potential solution, whether they're quick fixes or whether they may take a number of years to happen. But that's our goals tonight, so thank you. Our format is quite different tonight. Normally we have a panel of 3 or 4, and they each give a little presentation. Tonight, Rose is going to do a presentation for the first 15 minutes and tell us a little bit about what she does. And then we're going to hand it over to our 3 panelists to ask Rose questions, and we will do that throughout the evening. I also, in addition to their questions, I also have a list of questions from people who sent them in through the MCC Our Health email account earlier before the program. So thanks to those people who sent questions. But that's the format for this evening. So let's get on with it. Rose, tell us about your background. Tell us about what you do on a daily basis. Tell us about what you find most rewarding or maybe more challenging, and take it away from there and tell us your key priorities too. Thanks.
Absolutely. Thank you so much, Keith, and thank you to everyone who's tuned in. And I think it just speaks to the priority that we hold healthcare to be. And I have had, and I'm happy to tell you a little bit about my own personal story and how it is that I've been now able to carry forward the privilege and the responsibility of speaking on behalf of Ontario's 43,000 physicians. And so I'm the president of the Ontario Medical Association, and believe me, it's quite the time to be the president at the Ontario Medical Association. I started out as a family medicine graduate in 2001 and had intended to open a comprehensive family practice. I happened to marry one of my classmates, so we graduated as doctors together then, and he had finished his pediatrics residency, and we were looking for our town. We graduated from the University of Western Ontario, and where would we, as a new couple, hoping to have a family someday, where would we settle down and where would we call home? And for us, it was Aurelia. We met a recruitment officer at a fair where we got a lot of information about what was it like to move north of Toronto. And for us, having been graduated from McMaster Medical School and then our residencies in London, Ontario, I hadn't spent much time, to be honest, north of Toronto, the odd trip up to a cottage or so, but I was excited about something new and different for us. My husband definitely took on a full-time pediatrics practice right out of the gate, and we then also started to have our family. And so I needed to make some adjustments professionally, because in the next 4.5 years, I had 4 children. And so my kids are all now teenagers. I am a mom of a 13-year-old son, 14-year-old, 16-year-old, and 17-year-old daughters. And they attend high school in Orillia, and we still call Orillia home. But my practice over the years has transitioned. I didn't actually ever, for me, open up that comprehensive family practice. I think life dictated for me the requirement to be a bit more flexible. And this is a shout out to all my family physician peers who really carry the weight of a patient population through all of the hours and evenings and weekends that family doctors do, which is wonderful. It's an amazing model to build a trusted relationship with one physician that is your trusted advisor, your partner with all things healthcare, and helps you navigate the system. But I think back in 2001, 2002, 2005, I was starting to understand that for us as a family, I was going to work part-time, and shift work for me was a practical solution so that I was very involved at home. And I credit the family medicine profession because there is opportunity to diversify. So I worked in the emergency department, and I worked as an operating room assistant to the surgeons at the hospital. And I have always had a hospital-based practice, primarily looking after patients in hospital that don't have family doctors themselves in the community, or don't have family doctors that come into the hospital while they're inpatients there. At the top of the pandemic in 2020, I came to Waypoint Center for Mental Health Care, and that's where I currently am on the medical staff, working part-time as a hospitalist, which means I help look after patients, their medical issues, while they're being co-cared for by our psychiatrists. And it's a wonderful place to work. A few years ago, I became more involved in physician leadership. And I'll tell you the #1 reason why I was compelled to come forward as a physician leader. I was feeling the burden of physician burnout amongst my colleagues, and I was starting to feel it myself. And when I talk about burnout, I want you to know that physicians in general are high capacity, resilient, highly competent, compassionate professionals. And they go to work every day inside a system that now we are starting to universally recognize is a bit broken. In Ontario, we have serious gaps in our healthcare system, and your physicians are feeling it. So we've polled our audience, and about 75% of Ontario's doctors say they're operating at a level of burnout. And it's not because they don't have the internal capacity or the commitment and dedication. I think for the most part, doctors are those kind of high-achieving, conscientious types, and they will go to work every day and do their best. But like I said, and we'll probably get into it a bit more, there are gaps in our healthcare system. So I wanted to be at the table when we were having the conversations about what were we going to do to make it better. And so this is an elected position. I came forward to my peers after having spent a year on the board at the Ontario Medical Association, also having experienced physician leadership as president of our Medical Staff Association, sitting on our hospital board at Orillia Soldier Memorial Hospital, and interacting with members of the public and community leaders. I felt compelled to come forward even on a provincial level. And so when my peers saw it fit to name me as their president, that term for me began in May of this past year, and I have continued with that. We bring forward solutions, and we are committed as the Ontario Medical Association to work with all levels of government to implement solutions. And I'm happy to get very specific about those because we have done our homework. And in our 140-year history at the Ontario Medical Association, our prescription for Ontario, which is what we call the actual compilation of the document that we speak to government about every chance we get, that we speak to community about, that I speak inside media about, was the most extensively consulted plan. It's not actually just the doctor's plan to improve healthcare. It is members of the community, it is all healthcare stakeholders, from nurses to pharmacists to social workers to discharge coordinators, rehab therapists, and beyond. Every valuable member of the healthcare team poured into this document, and as Ontario's doctors, we carry it forward, and we're committed to seeing it implemented. And it's around really 5 key pillars. To touch on those briefly, I would say we have named it a priority to catch up on the backlog of care while we were dealing with the crisis of COVID that was ushered in overnight. You remember, right? March 2020. No one knew what was coming. And the entire healthcare system had to pivot, and we did. But what it meant was that elective surgeries and procedures got put on the shelf. It was nobody's fault, but got put on the shelf. Hip surgeries, knee surgeries, cataract, hernia repairs, some cancer screenings, even down to routine childhood immunizations or checkups at your family doctor just got put on hold while we were dealing with the crisis of the COVID pandemic. That's how we pivoted. And so what we know now is that over 22 million patient care services were delayed. Over 1 million of those are surgeries. We need to catch up on the backlog. Patients are getting sicker, and they're having to wait too long for good care. Secondly, we want an investment in mental health and addictions care in our communities. That has not been addressed seriously, and we know that in the community, we lack the team-based, community-accessible mental health and addiction support that we need. I would say especially in our rural, northern, and remote communities, but it's felt right across our urban centers and in every small town as well. Thirdly, we want to see an investment in a public health preparedness plan. We are going to have another public health care crisis. We have learned a lot through the crisis of COVID. We need to leverage that and implement it and robustly outfit our public health system so that it doesn't take us out at the knees, our economy doesn't suffer, our children don't suffer, the way that we all paid such a high price dealing with the crisis of COVID. We can be better prepared for the next public health care crisis. Also, we need an investment in our community home care and palliative care strategies. We know that that is lacking. And lastly, we want everyone in Ontario to have a family doctor. Over 1.5 million people in Ontario don't, and we know that that's the trusted relationship that everyone needs to help navigate the healthcare system, to have that voice of partnership and trust, to be a credible advisor when it comes to all things health. And so those are our priorities. It's packed into something we call the prescription for Ontario. Doctors write prescriptions all the time. So that's what that document is all about. And it's really up to, inside our publicly funded healthcare system, which we are very proud of, it is up to the payer as to how things and where and strategically what will get funded. But these are our recommendations, and we're committed to seeing them through. And so I am glad to be here this evening to speak about that, to answer the questions that I know will come from our esteemed panel, but it's just good. It's good. I appreciated the title of the night, What's Up with Healthcare. It's good to talk about healthcare. I know it's important to all of us.
Rose, congratulations on a nice talk to start the evening, but on your role, and you love it. We can tell you love it. But you're dealing with your own group of physicians, your peers, your colleagues, who I bet sometimes aren't real happy with the decisions that those in your place at the OMA make. And then you're dealing with government, who's you're trying to influence and change the way they think. To me, that's a really big job. Which parts do you like the best, or do they have to go hand in hand?
I appreciate the complexity. And I am surrounded, at the Ontario Medical Association, I'm surrounded by professionals from all walks of life. For sure, we are a member organization, and our members are Ontario's 43,000 doctors. But at the Ontario Medical Association, we have economists and lawyers and government relations experts and people who have been in the medical political advocacy field for decades. And so I get to work alongside them. And you're right, not everyone sees all the issues exactly the same way. And so I think an opportunity for me as a physician leader at the OMA is to lean in and seek to understand when we seem to come up against a barrier of understanding and a lack of alignment. But we're really only going to make progress when there is alignment. I learn a lot of things. Sometimes I come with my made-up opinion, and then after a conversation I realize, oh, I'm not 100% right 100% of the time. And so I think entering into those conversations, whether it's with my physician peers or with our ministry officials, I think the conversations get a little bit further.
Okay, great. We have not scripted the question part of the program, i.e., everybody has a list of questions, but we haven't actually talked about it amongst ourselves beforehand. So I thought it would be helpful if we had an order to the questions, so around what their content is. So we're going to start with access to primary care as the key question, and then we're going to branch into emergency wait times, home and community care, retention of healthcare individuals, and if we have time, we're going to talk about mental health, public health, and there's a whole list of things down there, but I wanted to make sure that we had time for the biggest priorities, and yet we're able to cover a fairly wide range of issues. So who wants to start about talking about access to primary care? Lisa, you comfortable with starting?
Sure. I'm always comfortable talking. So, Rose, as somebody who obviously hadn't spent much time in the North Simcoe area before graduating from medical school, I'd like to know what attracted you to Orillia, because as somebody who, along with Sandy, has been very involved over the years with physician recruitment, I think it's important for all of us as community members to know how we can attract family doctors, especially husband and wife teams, to our area to stay, as opposed to just come temporarily for a few years and then move on.
Oh, I love the question, because it brings me back to 22 years ago when we settled in. And yes, we chose the town of Orillia basically because of the people that we first met. We were looking at a couple of different Ontario towns, and even across Canada, we went out to visit a few potential communities. But it was our colleagues that we were introduced to first, the medical teams that we would become a part of. And honestly, within those first weeks of being introduced, while we were still checking things out, we were invited, I remember, into people's homes, and we were quite portable then. We didn't have any of our children yet, and so going to someone's house for dinner and being invited in as a potential friend felt wonderful. We were looking for community. And I remember working my first emergency department shift, and the community representative who had been on the recruitment committee and volunteered to introduce me to a few physicians knew that my husband was a cyclist and that I was a runner, and to be honest, that we were looking for a local church to be a part of as well. And so she sought out individuals that shared that common interest with us and introduced us to them. And then we started to form a friendship and get invited to the triathlon club, which I still am a part of today. Some of my best friends are the people that I met when we first moved to town. And then it was key when my children were born that I was able to connect with other moms for me that were at my same stage of life and to become integrated into the community that way. So we were so warmly welcomed. It really was the people, and everything else kind of fell secondarily. But I credit the retention and recruitment committee because there was even one small caveat. One of them was a real estate agent, and she sold us our property, and there we built our house. and that just meant we had more stakes in the ground that we were going to stay put. And that house we built all those years ago is still the house that we live in today, and we haven't moved. Our careers have pivoted slightly, but absolutely, yeah, we chose it as a home, and we're happy.
Sandy, Jamie, jump in.
I'll go second. Rose, thank you so much for being here tonight. It's wonderful to meet you. When I came to town, as we were saying, we had a husband and wife team who were our family doctors, and we have since transitioned to another husband and wife team who are our family doctors, which works out very well. They appreciate the fact that they can have that work-life balance. One supports the other. You don't necessarily know who you're going in to see, but you know you're getting quality care. With our very unique population up here, we have a large percentage of our people who don't have family doctors and can't get them. But some of the reason is because we have a poor population in some areas. We have a senior population that's relocated here who maybe didn't come with a family doctor because they're retiring up here. We have a huge boater population, or what we call a transitional seasonal population. So it's a big mass that ends up flooding our emergency or clogging up the work, so to speak. What do you see as the future of the family physician model? Is it only going to be the one-to-one, or are we going to start to see clinics pop up where, sort of like the husband and wife, there's a series of support people or doctors that can then create an environment where people feel comfortable coming in who don't necessarily have a one-on-one relationship, but they have a single location relationship.
Yeah, no, you're speaking into an idea that that has yet to be fully developed. But I heard a physician leader recently describe it this way: when you move into a new town, and you have young children, for example, and you want to send them to school. You don't think, oh, I hope there's a teacher in that area that will take my children on. You know, when you go and move to that small town, there's a public school, and the first day you arrive, you're going to sign up your kids there, and they will get their education. And so it behooves us to think innovatively and outside the box, because as much as I talk about that trusted one-on-one physician-patient relationship, which I think works well when there's enough, but there's not enough doctors right now. I think we have to think about new and different models. And you can still have a patient-doctor relationship, but with a small team of doctors that cover for each other, and there's a digital location for your medical chart that's easily accessible so that when you come in for your visit, and that clinic may be open 12 hours a day, 7 days a week, perhaps, if there was enough health human resources to staff it. And can you imagine the access and the ease? And then all the while knowing that the relationship is important, for sure confidentiality of your medical chart, but that is a model that I know is being explored. Change takes time. I'm not personally responsible for ironing out all the wrinkles as we, consider moving from point A to point B, but that is one model that I have heard talked about, and it's definitely worth exploring.
So Rose, who else is on that team? And what's their relationship with the doctor? So are these team members going to work for the doctor, or how does that work?
Yeah, so even inside of our prescription for Ontario, we talk about giving everyone in Ontario a family doctor, but not just a family doctor, a healthcare team that's wrapped around that physician and connected digitally. We are in a digital age. Our computer records exist inside, the technology that we rely on, sometimes more reliable than other times. But on that team is the physiotherapist, the occupational therapist, the pharmacist, the social worker, the discharge coordinator when one of your patients is in hospital and then they transition to community, and maybe from community to long-term care, maybe from hospital to long-term care, maybe from hospital to hospice, maybe from hospital to home with a palliative care team or a community care team of some sort to allow you to be and stay in your home and have the care come to you. And so there would be a physician connection inside of that healthcare team. But we know our healthcare needs are complex. Psychotherapists, family therapists, behavioral therapists, school liaisons that, sometimes it's problematic behavior with kids in the classroom. And wouldn't it be great if, we could extend the care that a child needs into their school instead of having them take a day off and go and sit one-on-one with a doctor. It seems like sometimes we do things a little bit upside down and backwards. Having a healthcare team that is easily accessible with every healthcare professional on it is ideal.
Sandy.
Thank you. You're talking about an ideal world here. Sounds very wonderful. I'm curious. I note that Mary asked some questions. I think the use of team for caring for a patient is part of the plan that you have projected through the OMA paper. But I think just slightly changing a bit, communication. How do you feel we can best market or communicate this system that might be available? I mean, it is available in some communities. What methods could be used to communicate? I find people will talk to you and say, really, I didn't know that. And we understand physicians themselves are busy, so how can that support, or how can it be supported that more people know what might be coming down the tubes or what in fact actually is working in some communities?
So I think I understand your question, but I may actually just reword it and see if I understand. You're asking, how can we get the message out? Like, how can we continue to advocate and be very clear about what our asks are for improvements inside the healthcare system?
That would be the first part. But then secondly, if it materializes, how can it best be communicated to the consumer, to potential patients, the access to that system? Yes.
So we are very committed to being very clear about our message and the solutions that we want to see implemented in the healthcare system. I meet with MPPs, members of provincial parliament across Ontario, every chance I get. I am in the media. I think since my term began being the main spokesperson at the OMA, I've had 175 media interviews through all the media channels, and wanting to be that credible voice that leads us towards a better healthcare system. So we are committed to being connected to our publicly funded healthcare system decision makers, and that is our provincial government, and to bring our solutions forward to them. We have staff at the Ontario Medical Association who sit on bilateral committees, and so, for example, we have our ministry counterparts and our Ontario's doctors counterparts talking even this week about how can we reduce the paperwork, the computer entry that physicians do that take them away from direct patient care. We know it's contributing to burnout. We need to sit down and look at the forms and the documentation requirements that are really tying physicians' hands at the end of every day on weekends and overnights, and just impact their day and disrupt their ability to see their patients face to face. We're also sitting down with our ministry counterparts to talk about the health human resource problem. We need to collect even better data and evidence to understand what type of doctor and how many are needed where, which community needs which physicians. You know, we don't even have really good data, and so we need to work with the government to establish that information base and then to act on it. So we are also active on social media and want to get our message out that way. Once some of our solutions are implemented, I guess I would want people to experience them organically. I would want people to come to the emergency department and not have to wait so long. I would want people to access, there is a Health Connect resource, which is a 24/7 online resource, a symptom checker to connect with a nurse to see, okay, do I need to go to the emergency department right now? Can I wait and make an appointment with a family doctor? But that's...
Rose, is that the 811 number? Mm-hmm. It's the 811, and it's the former telehealth. Mm-hmm. So anything that you call telehealth today automatically gets transferred to that Health Connect line, 811.
Absolutely, yes. Yeah. What was formerly telehealth is now Health Connect, 811. So there are some resources, but there's some glitches with the resources, and we would want those to be built up more robustly. I just know that the gaps are there. We are committed in every communication venue that we have to maximize that and to speak. It's really what Ontario's doctors do. Of course, we look after patients and we're there at the bedside, but those of us who've been set apart as the communicators are doing our best to get the message out.
Yeah, thanks. Lisa, we're back.
I'd like to ask
and we don't
follow-up
have to do this
question.
in order. Okay.
Thank you, Keith. I'd like to ask a follow-up question. So back in 2017, 2018, the government of the day was dismantling the LHIN, the Local Health Integration Networks, and the intention was to bring in Ontario health teams. We have an Ontario health team here in North Simcoe. Not every community has an Ontario health team, but my understanding has always been that the team would operate similar to the team that you were envisioning doctors would be involved in the future. And I guess where are things at?
I think that's a really important question.
Where are they at? Because we're not hearing, there are many, many communities even in Simcoe County and Muskoka that don't have a health team for their particular region yet, or a robust health team. Mm-hmm.
Perhaps it would be helpful to talk, you've been talking about a family health team, and now Lisa's talking about an Ontario health team, and to recognize that those are actually two different things.
They are, yes.
And so I think Lisa's question is around the Ontario health team and what advantages does it bring. Is that right, Lisa?
Mm-hmm. Yes, and where things are at in terms of the government's implementation of the Ontario health team, and does that actually conflict with what the OMA is envisioning will happen for the future?
So to be absolutely clear, there is no conflict between what Ontario's doctors want to see as far as integration of care and how the provincial government has determined to organize the province's healthcare delivery, which is inside the model of Ontario health teams. So we're very much committed to working inside the infrastructure, and you're right, there was definitely a pivot, no longer the LHINs and now the OHTs, the Ontario Health Teams. So, yes, I mean, you look at the textbook definition of an Ontario Health team, and it's a regional organization of all the healthcare players, the hospital, all the ambulatory clinics, all of the therapy hubs, and all of even the psychosocial determinants of health and where those resources lie, that it would be all integrated regionally so that people geographically would have access to those resources based on where they live and what they're close to. And from my understanding, regions are responsible to apply for that status, and then once they've gained that status, because they have met certain criteria, then they are named a team, an Ontario Health team, and resources are allocated. It's probably a simple definition, but resources are then allocated specifically to that team. So I think the pandemic was disruptive when it came to Ontario Health team formation. I think we have yet to see really the Ontario Health team vision be realized. I think it sounds really good because we do need more integration. We are dealing with a lot of disintegrated, siloed pockets of care. So I am hopeful too that as we're able to pivot a bit beyond the emergency of the pandemic, that we'll see more integration and the building up of Ontario Health teams. Thank you.
I'm going to flip to a question that I was sent, and somebody very eloquently said, I've lived here 2 years, I can't find a family doctor. What do I do? And are there clinics, walk-in clinics that I go to? Mm-hmm. And on top of that question, you said there were about 43,000 physicians in Ontario. I think the number that we could use is somewhere at least 7,000 or 8,000 more of that, about 15% shortage, just roughly. So how are we going to find those 8,000 family physicians so that this lady that sent me this question will actually have a family doctor?
Mm-hmm. Yes, I hear you and the person who would ask, what do? I don't have a family doctor. Because I work in the emergency department, and I might see someone who now newly has high blood pressure or newly has a diabetes diagnosis or has come in with chest pain and have had a short stay in hospital to deal with their cardiac event, but they need follow-up and monitoring and may now be on a new blood thinner, which is important to be tracked and supervised for, and repeat prescriptions written. So it makes me really uneasy, actually, as a physician, discharging people from the emergency department, discharging people from short stays in hospital into the community where they don't have a family doctor. And so I feel like I could answer that question maybe at two different levels. We know that in Ontario there are kind of stopgap measures when you're kind of in the moment. I mean, I'm thinking right now about flu, COVID, and RSV season, lots of coughs and colds. I know my kind of run through our household with my kids in school. And so there are a few places for people to go. I think it's very community dependent, but there are what has been the COVID-19 assessment centers have been with some government initiative have been pivoting to clinics that will assess any type of upper respiratory illness symptom. So a cough and cold center, and anyone of any age, whether you think it's COVID or the flu, or you're just not sure, it's your asthma acting up, this is a clinic, and there are, I think, about 60 of them across Ontario that are now staffed and able to receive patients, and you don't have to be referred by a family doctor. You could go to a clinic like that. Other smaller stopgap measures, Pharmacists can renew prescriptions without a written prescription by a doctor sometimes, and can also, there are walk-in clinics. It's not ideal because, as I said, the best long-term care is inside of that patient-doctor relationship. But walk-in clinics, especially those that have access to an in-person visit, if that's required, are still operating in the province, and folks can access that. And then, as always, we want our emergency departments to be open when it's when people are seeking care and they have nowhere else to go. Then, I mean, I've worked in an emergency department for 20 years, and we've always had a low acuity area and a higher acuity and a resuscitation area, and so we want our emergency departments to be staffed and open. So all of those things hand in hand, and system level solutions to bring in more doctors and bring in more family doctors. Now that is a different answer, but addressing the doctor shortage means that we want to address the causes of burnout. Why are family doctors retiring early? Why are family doctors streamlining their practice and not even caring for all of the patients that they have had in their patient roster initially, and it has a lot to do with all the other things that doctors have become expected to do. We want doctors to be doctors, and there's a lot of documentation that's come with the introduction of the electronic medical record, a lot of computer time, and we want the system to pivot so that those duties can be shared by other people on the team, so that a doctor can be much more doing patient-facing care. And we also know, lastly, addressing the doctor shortage, we have physicians that are internationally trained, that are living here in Ontario, that don't have a license, that are seeking a license. And traditionally, there's just been a lot of barriers for those internationally trained doctors, and there's almost 1,000 of them throughout Ontario that have trained elsewhere, but because of the requirements, it's costly, it's time consuming, and it involves multiple levels of bureaucratic paperwork and source verification of their training. Now, doctors need to be scrutinized and that their expertise is up to snuff, but if we could look at reducing the barriers and bringing physicians into the healthcare system sooner, we've crunched the numbers and we could have hundreds of doctors in place by the spring. So we're talking to government about that.
Okay, great, thanks. I do want to move on to a set of other questions, and I have a short break I want to take. Jamie, do you have any questions there about virtual care? Because we only really touched on that, and I know even from the questions I got, there wasn't a strong consensus around visiting a doctor versus virtual care. Or there was. They don't like virtual care, many of the patients, but there's some areas where it's useful. Do you have some questions around that or something?
My only question would be, and I had just heard this in passing because I was talking to my wife about it, and she had said, that should be taking some of the burden for those quick hit emerge room visits to be able to use Rocket Doctor, which was the one that we had access to. But now I understand that they've taken that back and that they won't be using it, and it comes down to the compensation structure of how virtual doctors are being handled versus in-person doctors. And just if you could speak to what is that conflict and what is going to be done to try to either enhance that virtual where it is applicable for people who, the younger generation are more technology savvy. They're very happy to sit in their living room, have a doctor visit and not drive a car, which is a lower carbon footprint, and all those things. But it also, it does take some stress off of the other parts of the system.
So to answer that question, I want to back up just a little bit, and that's to think about healthcare and the the family doctor care that was being delivered before the pandemic, less than 5% was being done virtually. We didn't have a requirement to see patients virtually. Everyone was able to move about freely. We didn't have a virus that we were having to keep at bay, and we didn't have the social distancing and the shelter in place and needing to stay home that we did when we were dealing with a global pandemic and the COVID-19 virus. Those early days, spring, summer 2020, physicians pivoted. We continued to see patients, and now we needed to make telephone calls, call people up on Zoom and all the virtual care platforms in order to keep that contact. Now, because doctors and patients realized this makes a lot of sense a lot of times. You need a prescription renewal, you need your lab results reviewed, you need really very, very simple things that require a quick conversation, a lot of mental health care, which is not a simple delivery of care, but a lot of that is actually even better done when it's virtual. There's something about being able to stay home in a kind of safer, quiet place and have those really vulnerable conversations with a therapist, with your physician, when it comes to your mental health. So we wanted virtual care to become permanent and that physicians could continue to deliver virtual care. And so we advocated for that fiercely, and just recently, within the last year, we were able to bring in a virtual care compensation framework that the provincial government also sees is beneficial for patient-doctor. Now, all that being said, we know that the best care is really inside of a relationship that you have ongoing with your doctor. If those criteria are met for an ongoing patient-doctor relationship, virtual care is paid on par. As far as compensation, it's matched dollar for dollar. If you're receiving virtual care and it's virtual only, it's true that as of December 1st, that compensation structure has changed, and we look at the evidence because we know that that overall, when you see a virtual only doctor, you're much more likely to require an emergency department visit even 30 days after that virtual only visit. If you're able to see even a virtual visit with a family doctor, someone who has access to see you in person if it's required, emergency room utilization goes down. And so it's difficult to endorse an ongoing virtual-only system when a lot of times patients, sometimes unpredictably, will show up for a virtual visit and then need to be seen. But in a virtual-only situation, that person is then left to their own devices to go to an emergency department to seek out an inpatient visit elsewhere. And so believing that the best care is delivered inside that patient-doctor relationship that is established, that's what we went to bat for on behalf of Ontarians, and indeed we were able to bring about a framework for that. And yes, virtual visits are great, but once again, the best inside of a patient-doctor relationship.
Thanks, Rose. I'm going to take a break for 5 minutes. You can breathe and pause, and then we'll get back to some stuff about the emergency department and ER wait times. So Josh, Glenn, I think you've got a couple of slides up there that say thank you to our sponsors. We are so grateful that they provide enough money that we can have you come here with no added charge, and we can make this show happen. Those 7 sponsors are 5 healthcare providers and 2 very interested supporters, users of the system. Audio Hearing Aid Center, Georgian Bay General Hospital, the Center for Psychology and Emotional Regulation, run by Anita Federici, Hillcrest Village Care Center, long-term home managed by the Enns family, and the Waypoint Center for Mental Health Care. And then the other two that are the users of the system, Mink Insurance, led by David Mink, and Lois Lipton of Georgian North Real Estate Limited, providing commercial real estate and development. So on behalf of us all here and the support you give us, not only financially, but just telling us whether we're doing a good job all the time. So we appreciate you being here. So let's give them a hand. Our next program is 8 weeks tonight, 8 weeks and 1 day exactly, on February the 16th. We're going to talk about the media, the news we hear from the TV, what we read in the newspaper, or what we access online, and the effect that it has on our health. Just think back 10 years ago, we relied probably on a single daily copy of the newspaper. We listened to the occasional newscast, and we'd watch our favorite channel at 11 o'clock at night, and that's where we would get most of our information. Today, the sources are very different. There's many more of them, and in many different ways. The information is available around the clock, the content, the format, very different. And so our next program is going to talk about how we filter that media information so that we can balance what's good and what's going to be challenging, and how we can get rid of that anxiety when you read these very provocative headlines. So we've got media people here, and we've got some psychology people here to give us some advice. So that program is 8 weeks tonight on February the 16th. I'm also delighted that we are going to have our first guest moderator for that program, and thanks to Scotty Warnick for stepping up to do that. So look forward to seeing all those people in 8 weeks, and I'll be watching it on TV from somewhere else, so my chance. Okay, put a plug in for the next blood bank drive here at the MCC on Saturday, February the 4th. And what I always say, and will continue to say, don't forget to get your bivalent COVID booster, and while you're at it, get your flu shot. That's probably the most important message tonight. So let's get back to our panel and our discussants, and we want to switch to ER wait times. And what we're hearing, huge numbers. And the numbers, I think sometimes the media try and get our attention by creating this awful, somebody waited 25 hours. Well, not everybody waits 25 hours, I think is the challenge. Who's got a question on ER wait times?
I'll go first. Often in our area, as I said, we have a diverse group, so a lot of people without family doctors. We have a lot of visitors from the outside. Our population swells. I think it was equated at one point, and I might be off on the numbers, but 43,000 visits a year to our ER, which is a small hospital. And that's the equivalent of some of the larger Toronto hospitals. And what are the steps that can be put in place to and maybe explain to us how people are processed through ERs. You work in an ER in terms of the severity of the need, how that's triaged and processed, and these people who tell these stories of extraordinary long, slept overnight at the ER. They obviously didn't have as concerning a symptom or a need as the people who are being processed. So how does that happen, and what can be done about the ones that are showing up in the media?
Well, emergency departments operate on a triage system, so it does mean that the sickest person is seen first. And so you've got an ambulance racing from a multi-vehicle collision, and there's life-threatening injuries. No one in that ambulance is going to wait in line. They come right into the door, and it's all hands on deck. And I do remember being called from a patient's bedside to come immediately to resuscitation room 1, and if we were there 30 seconds before the ambulance arrived, all the better. This person who is receiving CPR en route is not going to wait. I mean, I'm being a bit dramatic to kind of make my point that the emergency department does operate on a triage system. That being said, the waits that are happening in emergency departments are unreasonable. People shouldn't have to wait as long as they do. Even people who can wait shouldn't be waiting that long. I know that wait times have doubled and tripled. I've spoken to my physician peers, and it is really disheartening to know how long patients are waiting to be seen. I want to highlight why the wait times have blown up the way that they have. This is a way to understand it right now as to what is going on. Patients in general are sicker. I talked about the backlog of care. So you can imagine someone who's waiting for their knee replacement is now getting repetitive bouts of pain, becoming, maybe even having joint pain in the other knee or another ankle because they're compensating for pain at a knee. And that is, leading to more physical health problems when you're not as active and you have a cardiac condition. And it's been advised and that you're supervised in a cardiac rehab program. You're not able to do those daily walks because you're having knee pain, and so your heart condition becomes worse. And diabetes, we know, is managed well with healthy lifestyle, and so people are experiencing complications of their diabetes or their high blood pressure. All pointed back to, if only that knee could be replaced, which we know is the medically recommended route of care. But where people in the past were waiting months, now they're waiting years for a knee replacement. Those are the individuals that are coming to the emergency department with legitimate concerns, pain and dysfunction and complications of other medical conditions. And that's not even to mention the mental health overlay, the anxiety and depression that sets in when you're dealing with a physical health condition and you feel really stuck. Patients are sicker when they show up in the emergency department, and it takes more time to care for people. People don't have family doctors, and so accessing an emergency department seems sometimes like the only alternative. And this is also contributing to the waits. We know that emergency department staff ideally would see the people who come to the emergency department, but because there's such a backlog inside the hospital, when people are admitted to hospital, they still stay in the emergency department for hours and sometimes days. And so that then otherwise occupies the emergency department nurses and doctors and staff, because those patients are still physically in the emergency department, which reduces the capacity to see new people showing up at the front door of the emergency department. And so even investing in long-term care, options for people to be discharged from hospital safely, hospice care, as we talked about, and even home and community care would help to alleviate the strain of the resources that are being tied up with the emergency department overwhelm. So those are some of the reasons why we're seeing the backlog in the emergency department, and it's not right. It's not what we want to see inside the system, and so that's why we're advocating for change.
Thanks, Rose. This is a difficult one. Many people involved in the solutions for this one. Sandy, have you got any questions there from Mary on community care? Because I think we want to touch on a few things.
I do. Just if I may quickly reference another question that Mary had. It was a quote from the community, and I think many of us here and other communities too. Family physicians, when they are on their answering systems, are suggesting go to the emergency department. Is it not terribly, it must be hard for them leaving that message. But I'm sorry, I'm not answering your question exactly, Keith. But what can a community do to make different things happen? For instance, a lot of businesses go till 9 o'clock now in the evening. Is there a way that groups of physicians can offer an after-hours clinic? So that could be another option. In some communities, I think there is, I may not have the correct term, but there is a acute care clinic, is that a term that's used? They're often in close proximities to the hospital, but they're not in the hospital, and I understand they're staffed by teams of physicians and nurses, et cetera. That could be another offering. But can you give examples, or are there ways that advocacy can happen in a community to help? The ERs are squished at both ends. He said, you're afraid to admit, even though you think that's the best answer, because you have patients stalled in beds for various reasons. They refer them back to their family physician. Please see your family physician in a week. Oops, the family physicians are backed up 4 and 5 weeks. Do you have any suggestions? I just think of that message. That's where it all starts.
Sure, yeah. If you're asking what can people do to help the system so that family doctors are better able to operate and provide care, there are some really practical ways to do that. I was talking to a doctor just the other day, and she said to me, it's a difficult message to deliver, and I try to do it one-on-one, and I have fantastic patients, and she was bragging about them a little bit, because she said, you know what my patients do when they come to see me? First of all, they show up on time for their appointment so that I don't have to wait for them. They call and tell me if they're delayed or if they have to cancel. As soon as they know they have to cancel appointment, they let my staff know, which then frees up another appointment for someone else to get slotted into that's waiting to be seen. And also, when my patients come to see me and they know we're going to talk about their blood pressure that day, or their diabetes that day, or their congestive heart failure and how things are managing at home, they bring me a list of their medications, and I have a list also, but it's helpful for myself and my patient to be on the same page and bring in their medications, tell me, if you ran out of your prescription, how long ago was that? If you haven't been taking your blood pressure medication for a week, that's really helpful to know, because we'll just get you back on the same medication. I'm not going to add a new one. And so it's the small things that I think really, if you have a family doctor and you're able to anticipate what does she need to make my visit as succinct as possible, those are the small things. And like I said, this was a family doctor friend of mine, and she was bragging about her patients because she's been in practice for about 25 years, and she knows her patients well, and she knows her patients really well. And she was saying, this is what my patients do to help me out.
So this speaks to the partnership that some physicians talk about. You have a responsibility, I have a responsibility, and together. So those could make a difference. Okay, thank you. So no, in terms of the emergency, Keith, it was just Mary's comment that this is frustrating, and as a counselor, she would talk to a lot of people in her community. It's a frustration she knows about. And then her question to you was, if this recommendation is there, is this really, really a good way to use healthcare funds? So.
It's difficult. I mean, doctors want their patients to be seen and to receive care. None of us as doctors graduate thinking, oh, I only want to be a 75% satisfactory contributor and player in the healthcare system. We all want to be inside a system where the system is functioning well so that we can function well. Leaving a message on an answering machine to say, I'm not open today, or you can't access to me today. What your option is to go to the emergency department. I understand where that's coming from. We want people to be able to do something, and because of all the issues that I've outlined, that is often the message of the day, and I understand where it's coming from. So I don't blame anyone for doing their best inside of a system that's broken, and that's why we're advocating for system-level solutions. Mm-hmm.
Community care, so getting people safely out of the hospital into an environment at home where they can function better, more realistically, after surgery or whatever they've been in the hospital for, but even more importantly, as an option for somebody so they don't have to go to hospital, they can actually get the care at home. How's the OMA involved in that? Because you don't run community care access programs. It's a different name now, but tell us where your organization fits with that.
I'm glad you're asking me this question, Keith, because I had a meeting today about this. So what we know about our long-term care facilities is that they're not always adequately equipped to manage a new symptom, or a patient that's developing pneumonia, or has now got a new fever, or is having chest pain. As soon as the team at the long-term care facility understands that this patient is possibly getting sick, maybe getting really sick, they send the patient to the hospital. Now, wouldn't it be better if where the patient was at, there was the chest x-ray available? We have mobile x-ray machines, and we have digital ways of electronically sending that image out to be read by a radiologist and then have that report emailed back. We have point of care testing where you can get blood work done and results that come back within hours. We have physicians that are on call that want to provide the advice, but we need to give that advice based on some results of tests, results of x-rays, and results of lab. And so physicians' hands are often tied when you get a call from a nurse at the nursing home saying, we think this patient's developing a pneumonia. Well, we need to send that patient to the emergency department, and it's not good care. It disrupts the patient, and families get concerned, obviously. Patients who struggle with just confusion and underlying dementia, just being a new and different environment, and even waiting then for transfer to come back, sometimes for hours, because you fall down the list of priority transfer when there's emergencies happening out in the community. And so we need, I think, in this province to equip long-term care homes to manage more medically complex. And these aren't complex. It's just ruling in or out a bladder infection, ruling in or out a chest infection, ruling in or out a hip fracture. Of course, if your hip's fractured, you need to go to the emergency department. But if you've had a fall and you have pain there and your hip's intact and you just need the rehabilitation over the next couple of days, you need some pain control, you need a physician to weigh in on, the assessment of your hip, that can happen right where you are. And so that is going to be a way, and we're really pushing for this because our long-term care homes across the province are not adequately equipped to manage medical complications that arise in the moment. Sometimes these things happen overnight, and that's just even more difficult for a patient to be transferred out. And so that is a solution we see and that we're committed to seeing.
Lisa, do you have anything up specifically about community care? So I'm talking about a nurse that visits patients at home, and different than long-term care. And I like your suggestions for long-term care. But in order to keep them out of hospital or to make sure they don't go back to hospital. Lisa, do you have anything specific there?
Well, we know from the prescription for health care that it is so much cheaper to keep people in their homes. And with adequate care, we can keep them out of the hospital and out of alternative levels of care in the hospital and out of nursing homes. And when I was doing some research for tonight's presentation, I came across the 2012 Ontario publication created by the government that talked about making home care and community care a priority. And I was sad because we have not made it a priority at all, in my opinion. We have an aging population, particularly in North Simcoe. We have a number of people with disabilities who are released from, you know, a spinal cord injury from Lyndhurst Hospital and have nowhere to go except a nursing home because they can't access quality home care that allows them to live even semi-independently. So I guess from my perspective, knowing that it's a priority for the OMA, what specifically do you envision the OMA advocating for, other than a pile of funding that's obviously needed? But I'm thinking specifically in terms of the nurses, the PSWs, the attending care workers, the physiotherapists that are going into the homes that are working very different hours and for different wages than somebody working in a nursing home or the hospital.
You're absolutely right about spending money more strategically. It costs about $450 a day to care for someone in hospital. It costs about $150 a day to care for that same person, the same quality of care in a long-term care bed, and even less money per day for the same quality of care in their own home with community care support. And so we know it makes a lot of sense economically, and it's just better care. When you can be diagnosed with your pneumonia where you are and receive the antibiotics and possibly the intravenous hydration, fluids that you need, and the nursing support, and a physician weighing in as far as decisions being made and orders being left for a team in your home, that's better. And so it is built right into the prescription, equipping and empowering community care teams to care for people where they are. And that's an all-comer solution. Ontario's doctors recognize the value of every healthcare professional on the team, and we know burnout has affected every member of the healthcare team. Our nurses are burnt out, our social workers, and our therapists, and so we value every member of the team, believe they need to be compensated adequately and be valued, really be valued. So we're talking, about equipping community care teams. Specifically in the area of palliative care, we know that there are some communities that have palliative care teams on call 24/7. That's wonderful, but that's only, sometimes it's because of like communities that raise funds, and I know hospices are often the blood, sweat, and tears of valiant efforts of community members. I was just in Windsor not too long ago, and they were able to add an additional hospice bed. I think they were operating with 10, and now they have 11. And this was all efforts of the community. That's all well and good, but we want that public funds to come from government, and as community members we can be proud of what we do, but hospice care, palliative care, community care just makes a lot more sense. And so I think it's a shifting of resourcing to community. That doesn't happen overnight. That's pretty complex. That's a big sentence to say. But we know that it does need to happen. And so we're working with government to see that happen.
Thanks, Rose. I'm a little mindful of the time here, very mindful of the time. And the evening's gone far too quickly in terms of you've all got long lists of questions would have gone unanswered, but that's the way the cookie crumbles. I'd like to kind of end on a hopeful or a positive note a little bit, because we all live in the current healthcare system, and we've been dissecting the problems. where isn't there a problem? And I'm going to ask all four of you, where isn't there a problem in the healthcare system? What's working for you? And or from the stories you've heard, what actually is working that we want to say, don't change that? Who wants to start? Lisa, do you want to start this?
Sure.
I'm good at volunteering people.
So I gave some thought to that question. It's not a surprise, but I do want to commend our public health response to the pandemic. You know, they were able to organize and pivot and do vaccinations and send the message out that vaccinating was a good idea, try to manage the anti-vaccination movement with data and with resources, as opposed to just, you know, putting their hand up and saying you're wrong and walking away, but also managing everything else that they've had to do. So I do have to say that I've been extremely impressed with locally and provincially how the public health system has responded, and you know, particularly locally, I think we've done a very, very good job of managing the pandemic.
Sandy or Mary?
Yes. To your question about what is working, I'd like to read Mary's closing 2 sentences. I am hopeful someday we will look at a model of care that is equitable, timely, holistic, and most importantly, accessible, allowing people to live at home as long as possible, as they may, to live a long and healthy life. Finally, we appreciate our physicians and thank you for all you do, but it shouldn't be up to you alone. Doctors need to make it a team effort and share the burden with all healthcare professionals so we can keep our system strong and viable. That was Mary's comment.
Thank you.
I have 2 or 3 areas. I echo your comments about public health, and I wish we had more time because one of my questions about was, is it possible that there will be more funds go back into public health to do all the things they used to do so many years ago? There is a couple of areas in our system that I think works incredibly well, and I'm always grateful to be a Canadian, and that is where it's cardiac care, it's trauma care. We are excellent. It happens timely. People know their job, and they also do the follow-up, what you need to do to get back to moving, etc. Another area that I find very encouraging are innovations in orthopedic care, for instance, where one has a hip problem, a knee problem. We now know that outcomes are much better when one has physio OT input before. And I understand now that in some communities there are teams functioning where you see the orthopedic surgeon, you also see the nurse, the physio, the OT at the same time, and you see them afterwards as well. I think that one's working really well. And I do know that much as sometimes I grumble about access to my family physician, when I am in that office, I feel like I am receiving excellent care, considerate care, thoughtful care, and she is up to date on my history when I arrive. So yes, there are things that are very positive.
Jamie, what do you like about the current system?
My thought goes to some of the preventative and the support of preventative health care. And I think that that's becoming more of a focus of, you know, making sure people are aware of their nutrition, their obligation to keep themselves in good condition, see a doctor when you need to, but also, you know, take care of your health. We're learning through a pandemic not to go out in public when we don't feel good, which I think is going to help us all down the road. Hopefully we don't see another pandemic. But the thing I appreciate most is I only have to see my doctor once a year.
I won't take that personally.
No, I love my doctor, but it means that I'm doing my job to support them. I just go for my checkup.
Absolutely.
Thank you.
So Rose, I'm going to give you a chance to say something too, but really brief, but mine was the transport system that we have in Ontario, the ambulance service and how they seem to be able to respond, expand. Paramedics can do different things now than they did before, and they're open and willing to do those. And the orange system, the helicopter transport system, amazing system. So even though they're not seen in one place, the cooperation between organizations and moving patients is seamless across Ontario. It's a great system. Your chance, but I need a couple of minutes at the end to say thank you. So if you're not short, my thank you will be very short.
I'll make it very short. I wish I could have taken you all on my tour of the medical schools this September. I was able to meet with all 6 medical schools and their incoming new cohort of first-year medical students. Those were rooms of hopefulness. These were students that were very excited to be Ontario's next doctors. And I had a whole week traveling across Ontario from the Northern Ontario School of Medicine across Ontario as well. And believe me, we've got some great doctors coming into the healthcare system.
Okay, have we got enough though?
We're going to have more.
We're going to have more. So that's very reassuring. That's hope. Thank you. Okay, so my time has come to say thank you to our audience here at the Midland Cultural Centre, to those of you who are watching us on TV, and those who are online. But I really do want to say thank you to our speakers. We haven't done this format before, and time management was more difficult tonight than I have ever experienced before. But thank you to all for being prepared with the work that you did before, to know, what was really troubling people, and to bring that forward here. I think many of the things you've said have been very helpful. I think, Rose, you have been, you've given us a different view that we don't normally hear. We don't hear the voice of the doctors or the OMA, and you haven't just talked about the OMA, you've talked about the system. So we appreciate the approach you took to that. Thank you for taking time out of your busy schedule to come here. That was great. Sandy, thanks for preparing yourself in all of 8 hours today. And we'll thank you to Mary, who wasn't able to be here tonight, but did some of the hard work of putting the questions together. Jamie, as always, it's great to have you as, you haven't been a guest before, but to chat with you about healthcare, because you're the people's voice, so it's great. And Lisa, what great questions, my goodness. You must be a lawyer. Anyway, it's great to meet all of you, and thank you again. So let's give our speakers a big hand.
Well done, Rose.
Great.
We also have 7 sponsors that I mentioned before, and we're always grateful for their support. As I said, we will see you in 8 weeks. That's on Thursday, February the 16th. And the title of the event is Caution, News and Our Health. The information for that program will be out in posters and social media and e-blasts, probably the first to second week in January. Plenty of time so that you can register or you can find out how to access the program. If you'd like to watch this program again, or if you'd like to tell your friends and family to watch it, there's a couple of ways to do it. You can view it on Rogers TV if you have a subscription to Rogers TV. That means, though, that you can see it. It's probably on about 10 or 12 times a week, so just find out when it's airing, go to the guide, and you can watch it. Or you can watch it on demand, and for that you need the YouTube link, and we have that at the Midland Cultural Centre on our website. But to be honest, perfectly honest, I just Google YouTube Our Health, and the program comes up, and it'll probably come up later tonight because as soon as it's on the YouTube channel. So those are great ways to see it again. I'm always amazed at how I'm here, I'm participating, but I learn so much more when I rewatch the program. So maybe that'll be your experience. So to all of you, a very happy holiday season and good health for 2023. Thank you. See you in the next program.
call the Rogers TV viewer response line. Email us or connect with us on social media.
It isn't the heavy trays that make the job difficult, or the fast pace you need to keep up. It's not working another double because someone called in sick. What makes the job tough is the moment you realize a customer has had enough, and you have to make that decision not to overserve. Refusing service isn't personal, it's the law. We know it's not easy, but we're counting on you to keep us all safe. Thank you, servers, for doing the tough job.
Wait a minute. What year is it?
Monday, January 2nd.
If you don't keep making it through these leaps, you will get stuck in the past.
How did you do that?
Magic.
It's you. You're the woman I love.
How did you know that was going to happen?
I just remembered it.
We need to focus on the present and get back to Ben and Addison in the past.
Our lives are so insane.
Yeah, I heard it.
Quantum Leap. New episodes return Monday, January 2nd on City TV or stream on City TV Plus, the app, or citytv.com.